Hello, everyone. I am Dr. Erine Raybon-Rojas. I am the Director for Diversity, Equity, and Inclusion here at Northeast Georgia Health System, as well as Chair for the Department of Medicine. I wanted to welcome you back to our series, Diversity in Medicine, particularly Women in Medicine. I have with me here my friends and colleagues, Dr. Betsy Grunch and Dr. April McDonald. You guys have seen them in previous videos before where we have talked over so many issues. So just wanted to welcome you guys back for the rest of this conversation. So starting off, we are going to start talking about mental health and what that means for physicians, for healthcare, for ourselves, and for our patients. So I want to start off by talking about COVID really did change the landscape of healthcare and also highlighted a lot of things surrounding mental health, not just with patients, but specifically with physicians. Mm-hmm. One story that always I think about all the time is Dr. Lorna Breen. Mm-hmm. She was the emergency room physician that committed suicide and survived COVID, but ended up committing suicide because she had some mental health issues during COVID, which is completely normal and acceptable for an ER physician who was in a hotspot of a global pandemic. Mm-hmm. And the reason why she committed suicide was really nothing to do with COVID, but because she needed help and had to get help, she was so afraid how she was going to be viewed by her colleagues, and not even by her colleagues, by the healthcare system. Mm. So my first question for both of you guys is, have you ever had to be on the receiving end of a suicide or possible suicide attempt phone call for one of your colleagues? Ever experienced that?
I mean, I can kind of talk to some experience around kind of my training as a resident. I didn't exactly field that phone call, but we mm-hmm. had, I mean, where I did my internship was pretty tough. Mm-hmm. And being a general surgery intern, there's a lot of responsibility. Just to talk about these things was tough. You're supposed to be the surgical intern. You're supposed to handle it. You're supposed to just, take that things that are given to you and give it with a smile. And it's a little overwhelming. And so we had an intern that was with me on night shift and on night float, as we called it. You worked with a variety of different surgical services, and the stresses were high, and you really wasn't, you didn't want to call your superiors unless you really needed it, and you're a new doctor, and we had one of our interns go into the nurse's call closet where the supplies are kept, and he slit both of his wrists and down the radial artery, and one of the nurses found him in there, and he's taken to our emergency department and was resuscitated and revived. But that really was hard on all of us, and no one wanted to talk about it. So it was this hush hush, so and so is going off service because something happened, but everybody knew what happened, and there was no support there. It wasn't let's talk about what you guys may be going through. Let's talk about how we can make positive changes. How can we help you?
So no debrief at all?
Nothing. Zero. We didn't even know what happened. So it was just, something we all knew happened, but then we didn't really have any support to really talk about it. And it was tough. And at the time, I thought that was normal, which further made me want to suppress those feelings. And now I come to realize, and as I've matured, that was wild. Yeah. That was not good. So I think, just having the opportunity to have these conversations, which are not unique. All of us have these feelings as we mature through our medical career, that we need to ask for help. We need to have conversations with our younger trainees, with our medical students about what's acceptable. You don't have to deal with this. Yeah. Reach out. We're here to help. Yeah. And I just think it's important. Yeah.
So answering that question for myself, I've actually been that call 3 times now.
Wow.
Yeah. Two physicians and 1 nurse. And my first one was during COVID, and I was talking to a nurse, and she was talking about she was going to drive off a bridge, and so went about the process to make sure that she was taken care of, and she's doing amazing now. And 2 fellow physicians, getting them help, but also it's not even just the call, because there's this incredible weight that you feel too when you get that call. It's just like, because then they're like, okay, hey, I think we need to go ahead and bring you into the emergency room, and then and so you start that process, and they get angry at you. And they're not angry because they don't want the help. It's, I think, shame and embarrassment. And then Dr. Breen's situation, or for that resident that in your residency, the questions we have to fill out every time we get credentialed about, have you ever had this and have you ever had this? And despite normal things happening to us, just because we're physicians doesn't mean we're not people. Normal things happening to us, it's like we're not allowed to feel. Like you said, you were like, I thought this was normal. Because that's what we're taught, really. Or it's not that we're taught that. We're not told anything different. Or back then, we weren't told anything different. So just picking up, like, if a friend of yours slit their wrist in the bathroom, that would be a big deal for the family, for whatever happened. You literally probably just had to keep going on that shift, and the next day and the next day and the next day, like nothing happened. That to me is not normal. And that is the purpose of what we're doing here. I think that's the first part of what we can actually do, is call a thing, and that's not normal. I don't know, Dr. McDonald, how you feel about that?
I think, our environment that we train in, that we work in, is still very much one that is not kind to those who show this idea of weakness, right? And so, weakness, and these are, and actually truly the people who you've discussed and said who came to you. Yeah. How brave of them.
Absolutely.
How incredibly courageous and brave to voice what they're feeling and seek help. But far too often we suffer in silence. And we can be surrounded by so many people around us, and yet we don't really share what's going on. We say, I'm fine. When someone asks you how you're doing, I'm good, I'm fine. Because we think that's what's expected. But it's all about changing that environment. We have to, exactly what you said, normalize this, normalize these conversations, normalize these feelings in the way of, we all go through something at some point in life, and training in life, and when we're working, whatever, and it's okay to have these conversations and talk about it.
Yeah.
I think it's a testament to you, Erine, too, about how comforting you must be as a friend and as a colleague for them to feel comfortable coming to you.
It's a matter of vulnerability. If one person says it, maybe you feel more comfortable saying it.
Yeah.
During COVID, it was so, and even after COVID, even now, I would say just in our pulmonary and critical care group, and not just our group, like just with my colleagues around the country, like there are some serious depression, anxiety, PTSD that is just really not being addressed. And I kept thinking, like, why are we not addressing this? Why are we not talking about it? Because how many times do you tell your patients, take your medicine, get your annual exam, or, you pick up something during a visit and you're like, hey, let me go ahead and refer you to behavioral services, behavioral health. Like, we coach people on these as physicians day in, day out. But do we do it ourselves? No, we don't.
We're the worst at it.
Right. We are the worst at it.
Self-care.
And so I think for my part, as far as one of the things that I feel like I can do is what I'm doing right now is to just put a name on it. It's anxiety, it's depression, it's PTSD, it's, so many other things that we get from working in this field. There was a post on Instagram that I saw, and I want to ask Dr. McDonald specifically about this one, because it was a post that was about someone essentially passing away, and then how, chaplain comes in, there's support for the family and kind of that. And then for us, what do? We go to the next room, mm-hmm. right? And especially for us in critical care, where mm-hmm. we're, resuscitating or, So I wanted to ask your particular perspective about a situation where that you've encountered, where either yourself or a colleague, and kind of, I want to hear your thoughts and what is something we can do about that? Like, what are some ideas?
I think, really truly just being emotionally available, mm-hmm. right?
Emotionally available. I like that.
In the way of, I think in our training, for some reason, and again, this goes along with us being type A people, but then also just the training environment frowns upon this idea of weakness. And so people start to become shielded from things and feel like they can't really show their emotions. But truly, for me, and what I've always tried to do is, sometimes I cry with patients. Mm-hmm. If I feel it, I do it. Yep. And not, to an extent in the way of, showing that vulnerability just shows how much I care.
Absolutely.
And that I'm a human being, mm-hmm. and that I'm really there and I'm invested. Mm-hmm. And so I think allowing yourself, whatever emotion you are feeling in that moment, to be present in that and not restrict it, mm-hmm. is helpful and healthy. Mm-hmm. And then it allows you to also cope and move on. Yeah. Yeah. I think when you start to suppress things, that's when it starts to ruminate and really become, fester over time.
Yeah. I will say that within graduate medical education and, having mentees of, residents and fellows and even medical students that are coming up, what I find myself doing is actually counseling them differently. Mm-hmm. Because I feel like sometimes medicine, the practice or the preparation for the practice of medicine, stomps out your personality. Mm-hmm. It's like we're all these Stepford wives and husbands that are like robots. Yeah. And we're people, we have feelings, we have emotions. And I think that once I brought that, and obviously, honestly, I got that post-COVID. I've really tried to bring that, philosophy to all of my mentoring, ensuring that there is wellness all around. Like, if you are, rocking exams and tests and, things like that, but you're hanging on by a thread, you're not doing well. You're not winning. Yeah. You're not winning. And so really redefining what strength means and what weaknesses mean, because I used to look at strengths and weaknesses really different. Strength to me now is more resilience, and I say flexibility is a superpower. Being able to change and be amendable to the situation around you. But the other thing that I have also started doing is doing debriefs with my team after we have not even just a patient pass away, but like an unexpected an event, or it could be an act of violence against, a staff member. It could be anything that's going to trigger an emotion for a normal person should trigger emotions for us. And I want to use those times where I have my team together, be like, all right, so y'all know that's not normal, right? And people are like, oh, really? That's not normal? Like, yeah, this is not how it should go. And I ask, like, how do you feel? And they're just like this. But you can have feelings. You can have emotions. You can cry. And some people, like, you see them trying to, like, go in a corner after someone passes away and, like, kind of, I'm like, no, you can come up here and shed tears and be with the team. And, this is a life. This is a sacred thing that we get to do. But we're allowed to have feelings. So the point is, to your point, Dr. McDonald, is creating the space, being emotionally available, and redefining what strengths and weaknesses really, really are. Because in my mind, the way I kind of go about, these situations and my own mental health and mental wellness is trying to be as vulnerable as I feel like I can be with those people that you feel like you can be vulnerable with. Getting the help, that I felt like I needed post-COVID. I am the first person to say I did some interview years ago, and someone asked me, like, are you going to get counseling after this? And I was like, absolutely. And I wish I hadn't waited. But because it was just, like you said, build up. And I got to a point where I was just like, well, what do I do now? Because it was so much. Like, when we all deal with death on a daily basis, but when you have 13 people die in a 24-hour period, you can't tell me that you're not going to be affected by that. You can't, like, that is not normal. And what did we do? We all came back to work the next day as if everything was just fine. There was no conversation about it. My resident was so torn up. I had just gave him the day off because he was through. And interestingly enough, he's now a pulmonary critical care fellow, so that didn't scare him away. But normalizing what used to be, redefining what is normal and abnormal as far as mental health and physicians and healthcare goes. I honestly think that we can talk about this all day, but where it really has to come from is advocacy and policy changes. I know that there was a whole bunch of funds, federally for mental health, but, as a discipline, not even just as a hospital system, but as a medical discipline, has anybody reached out to you to talk to you from like your board specialties or anything like?
I was actually surprised as a neurosurgeon. I mean, obviously this is...
Because there's like 5 of you.
Not many of us. But at our national meeting that I just got back from a few weeks ago, there was actually a committee on physician wellness and a whole series of lectures, and I'd never seen that before. So I think these types of feelings are being propagated, and I think it's great. I mean, there was a whole exercise, yoga, meditation, but also real talks about these things, and just that movement was very inspiring to me because that's never anything that I've seen on a national level. So I think that may be a sign that things that that we're talking about this more, which is important.
Mm-hmm. If you could pick, actually, I'm gonna ask both of you this question. If you could pick two initiatives that if you were sitting at the top of ACGME and you had, you could just
go first.
Nope, you picked.
and then all you had to do was write this, and it was a decree for all of graduate medical education at the ACGME level. Actually, I'm gonna give you 2 things. What one thing would you ask, or what one thing would you decree in regards to?
I can go first.
In regards to mental health and wellness in physicians, specifically training physicians. So it could be something that you want to change, something you want to do, an initiative. What is going to be your decree?
So I'll go first.
Go ahead.
Okay. All right. I would say things that I've noticed in my practice that I've tried to enforce with my team has been protected time off. I think particularly in trainees, we talk about the golden weekend, like the one weekend out of the month or whatever it is that we get off. I think we need more than that. I think, even potentially enforcing some time of a flex day off. So like you said, you had this resident that had this experience with a horrible, case, or, maybe a surgical resident has a complication that really rattles them, that they have a protected one day off a month that they could utilize for,
Wellness.
For wellness, but it's protected and it's available when they need it. Because I think that we all kind of need those
A mental
days.
health day.
Yeah.
Yeah. So mine is going to be that infertility workup for both men and women would be fully covered financially by graduate medical education. And the reason why I say that under the mental health aspect is because we are all, have had, 7 years of training for you?
Something like that.
7?
So 6.
Yeah.
Well, if
And
you're talking about residency training, 6.
Yeah. So, and then fellowship. So we at a minimum, after med school, we're all at 6 years.
Yeah.
So we're talking 10 years right there. When are you have 4 days off a month,
Yeah.
right? When
Yeah.
are you supposed to,
Maybe.
right? As a trainee, like when are you supposed to, you're so focused on your career. And by the time you get to that graduation and that goal, you find out you got some issues. And again, this is men and women. My decree on day one would be to ensure that there is not only specifically financial support, but that there is an acknowledgement of this amongst physicians and in graduate medical education, and then a plan. I will say that at our particular institution, which I'm extremely proud of, we know that women on working nights in the first trimester, night shifts have higher increase of miscarriages. So our ER program, if you choose to disclose that you are pregnant in the first trimester, they will make sure that you do not work nights.
That's really good.
And there's so many things that our programs are starting to do now here in our hospital that are actually focusing on these particular things. So I am super excited that I have an opportunity to be a part of graduate medical education here. Dr. McDonald and Dr. Grunch are mentors in graduate medical education here. So the fact that we have programs that are not just talking about it, but are actually trying to see how they can be the change is super, super amazing and very, very important. And that would be my push, would be to continue that. Dr. McDonald, you did not go yet.
I have mine.
Go ahead. You have your decree. What is your decree?
Okay, I'm going to take this a little bit differently.
Okay.
But it's so important and so necessary. So my decree would be to do specific financial wellness classes
Ooh, yes.
within GME, so that by the time you are out, so to really figure out what you're going to do with your plan with loans, things like that, but then once you're out and about and in practice, how you're going to make yourself money, but then also make yourself so that you can retire and retire when you want to.
Yeah. Which
And not
affects your
feel
mental
at
health.
all,
Yeah.
exactly, and
Yeah.
not feel
Like this
financially
pressure.
pressured
Absolutely,
at all. So
yeah.
I think that would be my decree.
That's a great.
Oh, I love
you
that.
You had good ones. Both of y'all have good
Right.
ones.
No, yours was really good too.
Wow.
Yes, love that. All right, so we are about to close out here from our Women in Medicine, Diversity in Medicine podcast. We talked all about mental health. I hope that you were able to listen to our experience and at minimum, feel that you're not alone if you're somebody that's experiencing that, or if you're somebody that is supporting somebody that is experiencing that, to know that, these are conversations that are not easy to have, but we are glad to be sitting here having this conversation. To Dr. McDonald's point about financial literacy, if you are lucky enough to be here at Northeast Georgia as a resident within GME, actually one of the things that I will be doing in 2025 is bringing some financial literacy to our graduate medical education department. And specifically just what you talked about. You have this insurmountable amount of debt, or you have family obligations or responsibilities. For me, I'm the first physician in my family. My life looks different than everyone else. And so how do you navigate that as being a successful doctor when you have, a mountain of debt that is literally almost, as tall as me. So that is one of the things that we will be talking about in 2025 is financial literacy and how that works in to your life as a resident or fellow. All right, we have again talked about so many different things. We have had some great conversation. I want to first say thank you for joining us and to end on a note of saying it's okay to not be okay. It's okay to say you're not okay, and it's okay to get help. And that is actually a sign of strength. I want to thank you for joining us. We have so much more that we're going to be talking about. We're going to be talking about imposter syndrome. We're going to talk about representation in medicine. We're going to talk about so many things as we're continuing this Women in Medicine series. So please, 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 we want to hear from you. We want to know what you thought about this, what you want to hear more of. Also, and more importantly, not more importantly, but as important, you can get CME credits for this. So if you answer the 3 questions from this podcast, you can get CME credits. So please like this video, comment, share it, and we will be back with more. Thank you.